All right, thanks very much for the opportunity to speak today. Um, yeah, so as Renza said, I've just started my PhD, but I've been working for a little while in the field, and I'm really excited to get to talk to you about this today because it's so early in the project, and it's a really exciting project, in my opinion. Um, so bear in mind that this is essentially a plan, right? So there won't be any results, but we do have a little bit of simulations to show you. Of course, they don't say anything about the hypotheses, but what they do demonstrate is sort of the feasibility of the approach we're using to be sensitive to what we expect to find. So there's a really exciting, groundbreaking clinical trial going on at CAMH right now, led by Dr. Lin, who's, I think, in attendance here. In this trial, it's actually the first time that psilocybin treatment will be applied in autistic population. And so we'll be collecting, qualitative assessments, resting state fMRI, and also certain cognitive tasks that I'll describe in just a minute. But this is the first time that this is being done. And I don't think I need to explain why this is important to look into, but in case you didn't know about this, depression is quite a bit more dangerous for people with autism. So the risk of death by suicide has been estimated at 8 times higher for individuals with autism. And it's also more difficult to treat. So current conventional therapies like SSRIs aren't showing quite as much efficacy in this population. So basically we have this, educated guess that psilocybin may be more effective where SSRIs are not. And it has to do with the differential mechanism of psilocybin compared to SSRIs. And we think that this mechanism actually makes it more suitable in for the autistic group. And I'll get into the approach, which involves this active inference model of hopelessness, which was developed by my colleague Povilas Carvelis and my supervisor Andrea Diaconescu. So like I said, no results today, but I will go through some background to motivate our hypotheses and of course explain our modeling approach, stating the hypothesis in modeling terms, make them a bit more precise, and finally to share some simulations, like I said. So starting with the background. So why is it that risk of death by suicide is so much higher in the autistic population? There's a number of proposed factors, from affective reasons to trauma, so acquired capability for suicide. Also, of course, social factors, isolation and loneliness, and finally, cognitive differences. And all of these are quite interesting avenues for research. But today, of course, we're going to be thinking about thinking and look into specifically how these cognitive differences might be the culprit. So in particular, when we think of autism, I think what comes to mind first is like sort of this sensory sensitivity or low level weakness of priors over belief updating. And at the same time, we also have to think about what I'm going to be calling rigidity. So rigidity is specifically in belief updating about higher order beliefs. And these include self-concepts. And I'm sure you're familiar with the rigidity in behaviors, insistence on sameness, intolerance of uncertainty. And you can think of these differences in terms of dual process theory. So somebody mentioned Daniel Kahneman. And as well, there's also a dimension along context. So familiar contexts, we have stronger priors, unfamiliar, weaker. And this is related to also difficulties in updating beliefs in response to shifting environmental contingencies. So I'm going to bring together this idea about higher order rigidity. And this is what I'm sort of calling impaired unlearning. And what we want to focus on is in the depressive state, this is particularly problematic because a lot of these higher order beliefs are negative. They have a negative affect, and you might translate this as hopelessness, rumination, etc. Maladaptive beliefs. So coming back to SSRIs, the mechanism of SSRIs in a nutshell has to do with increased top-down control of this emotional processing of affect. And this has been looked at and basically we come to the same conclusion, but it has to do with particularly this ventromedial prefrontal cortex amygdala connection. So the amygdala responds to emotional stimuli and the PFC controls that response. What SSRIs don't address is this rigidity aspect that I'm talking about, this impaired belief unlearning. And so what I'm coming towards is like, for SSRIs, we don't see as much efficacy in the ASD group. And this brings me to psilocybin as a potentially promising alternative. So psilocybin is a classic serotonergic psychedelic. And in a nutshell, it basically does what SSRIs do not do. And this is described very nicely by Professor Friston and Robin Carhart-Harris in their Rebus paper. So in that paper, they basically put their arms around the pharmacology, phenomenology, and cognitive neuroscience, all involved in the mechanisms of the psychedelics. And the takeaway is that what psychedelics do is decrease the precision weighting of these high-level beliefs. And the term rebus stands for relaxed beliefs under psychedelics. So we think of rigidity and then we think of relaxation. Basically, there's a time window around the dose of psychedelics where there's an opportunity to visit different belief states and potentially reform, unlearn maladaptive beliefs, take on new beliefs. And you can express this in terms of increased entropy during this period, increased brain entropy, increased interregional connectivity, decreased self-inhibition. And this is borne out actually in our research on LSD. And a recent study showed that for participants with depression, psychedelics really did decrease the confidence and negative self-beliefs. And that was Ziefman. So in general, psilocybin-assisted therapy has shown effectiveness in treatment-resistant depression in the non-autistic population, but in particular, we think it may be useful because of this rigidity aspect. So a hypothesis in general terms, rigid high-level negative beliefs or hopelessness. It's a hallmark of depression and a risk factor of STB or suicidal thoughts and behaviors. And this rigidity aspect, so not the negative beliefs aspect, but the rigidity aspect, we think is of particular relevance in the autistic population, not addressed by SSRIs, but seems to be specifically modulated by psilocybin. So our expectation is that the antidepressant effects of psilocybin-assisted therapy on autistic individuals will be driven more dominantly by the psilocybin-enabled unlearning, as opposed to what you'd see with SSRIs, which you can think of as like emotional blunting. Okay, so now we'll go through our method, which pertains to a task and model of the task. So the task has been put forth to measure these risk factors for suicidal thoughts and behaviors. So hopelessness, Pavlovian bias, active escape bias, probabilistic learning task. And it's shown to be able to differentiate the suicidal population with healthy controls. And the idea here is the same rigidity is modeled by the active inference model developed by Andrea and Pobilas. This rigidity, we think, will be a good way to look at, or sorry, the model will be a good way to look at the rigidity associated with this particular group, the ASD TRD group. So to go through the task pretty quickly, essentially, it has to do with stressor stimuli. So on each trial, the participant is presented with an image, and yeah, so an image, and this image is connected, played simultaneously with an auditory stimulus, and it's aversive, right? It's like a scratchy, bad sound. And based on what image you're seeing, you may either hear the sound or not. And the subject has two options in terms of response. They can either press a button, which is the active go response, or do nothing, which is the no-go response. And there's basically a mapping between, if you hear the noise, do I press it to escape the noise, or do I do nothing and the noise will stop on its own? Or in the other case, if there's no noise, do I press the button to make sure that the noise doesn't come on, or do I do nothing because the button will make it come on? So this mapping between what image you're seeing and what response you should do to avoid the noise, it's about 80% strict. There's some uncertainty, which just makes it a little bit harder to learn. However, an important aspect of this is that after a certain number of trials, this mapping will reverse entirely. So the subject will have to relearn. So active escape bias is essentially a phenomenon in which the participant preferentially selects the active go response, whether or not it's actually correct, if they had learned the game properly. And this is present in the general population, but it's heightened in the STB population. And this is a type of Pavlovian bias, right? So it's like, no matter what kind of learning I can do, my best option is just to hit the same button given this stimulus. So in healthy agent, basically active inference would tell us if we're seeing them select the instrumental policy, it means they have beliefs that this policy will be the better one. And in a high active escape bias participant, what we're inferring is that they don't have a belief in the efficacy of these instrumental policies. So that's the Pavlovian bias. And we believe that this is due to two things broadly: overweighting of aversive outcomes and this high level rigidity. So I don't have time to go through this, unfortunately, but what we want to know about is how do these experiences of the trials contribute to the updating of beliefs? So I don't think I can point, but basically we have U as a control state. So this equation changes depending on whether the idea is to go or no go, the policy, right? And we have two terms other than the previous belief, right? We've got this term with a eta in front of it, and that's representing new information. And the term with the lambda in the denominator, that's representing the old, it's like a discount on the old belief. So to get this down to easy numbers, we've got eta, which controls the learning rate, lambda controls the belief decay rate, and there are some sort of underlying parameters, the parameterization is a little bit arbitrary, but each of these is proposed to be connected to certain neural circuits, and that's where the domain knowledge comes in. But we're really interested in this belief decay rate threshold, which is M, and belief decay should depend on state action prediction errors, but with a too high M value, we would see less learning, less unlearning of previous beliefs. And again, I think this is too much detail for how much time I have left. So to go through the hypothesis again, this is the clinical trial we're looking at. We believe basically the effect of psilocybin will have to do with reductions in these belief decay thresholds as opposed to reductions in learning rate parameters, which associate more with the mechanisms of SSRIs. Okay, so for simulations, again, this doesn't prove anything about the hypotheses, but this is what we would expect to see. We tune the parameters to give ourselves these sort of ideal agents, control agent, pre-treatment, so the autistic treatment-resistant depression group, and what would happen after treatment. And so we just do kind of a true to life-ish simulation of that, and we get this effect. So in the neurotypical control group, this black line represents reliance on the Pavlovian policy, stays consistently low. This purple line represents an active escape bias. And again, it's lower than the other agents, particularly the top agent there, which is the TRD-ASD group. And if we look again at the Pavlovian policy, especially after that midpoint Q reversal, so left to right is like the trajectory of the experiment. This black line definitely dominates after this Q reversal. So it's like inability to adapt to changing environmental contingencies. And on the left side, you've got the much larger gap in the active go response, which is by simply changing the underlying parameters, the performance of the task comes closer to the neurotypical control group, where this Pavlovian policy is not dominating before or after the reversal, and the active escape response or bias is attenuated as well. And this is just additional simulations just to show the same effect. Carries over with a little bit more variance in and noise. And I think I have to wrap up. So obviously this is interesting because we can test out the validity of this model, which seems to isolate one factor of the mechanisms of psychedelics better than I think what I've seen so far. And we're also empowered to do connectivity analysis with the resting state fMRI data, and that'll allow us to validate the proposed connection to neural circuits as well. So I think it's a very promising approach because that task is very easy to implement. In fact, on my poster, there's a QR code. Anybody can take a picture and play the task themselves. And it's also another opportunity to potentially add more evidence to this rebus theory, and maybe even apply this technique even further to more what we might call canalized disorders, so OCD, substance use disorder. So that might define a pathway for future work. I think that's all for now. So thank you very much for listening.